Thank you for this nice introduction. So my name is Xiaoxi Yao. The first name sounds like Xiaoxi. It means sunlight in the morning in Chinese, but it's super hard to remember or say in English. But it means sunlight in the morning. So for my parents, it's like calling my sunshine. But if it is so hard to remember, you can always call me Dr. Yao because that's why I got a doctoral degree, right? So I am the endowed scientific director for pragmatic trials and evaluation. So the role of my team is to serve as an unbiased evaluator for different innovations that could include things like a bridge, but can also include other AI technologies, drugs, and devices. So I also have a joint appointment in cardiology because my closest collaborator is Dr. Peter Noseworthy. He's a cardiologist. And I just took a selfie outside for this Noseworthy hall. It sounds like his hall. But so a lot of work I will be presenting today is with Dr. Noseworthy. And my other role is associate editor of JACC, Journal of American College of Cardiology. That's one of the top 3 cardiovascular journals. So if you are doing anything in CVAI, feel free to reach out to me too. I heard many of you are data scientists. I'm not, so I'm a health services researcher by training. But today I will talk about how we, the evaluators, approach the evaluation of AI. So we typically look at from 3 stages. First is the AI algorithm need to have some basic validity in the performance, right? So you have to predict rather accurate of what you intended to predict. And that's actually not that straightforward as you think. Traditionally, we just develop, or healthcare has been developing prediction models for forever. Like for example, for mortality, 30-day readmission. So for those more traditional questions, you actually, it's not that hard in comparison to other things I'm going to talk about, because for mortality, you actually can easily adjudicate whether someone died or not, right? Same as 30-day readmission. So for those kind of things, this is one paper our colleague and friend Zaki Attia did many years ago. So for this kind of predicting one outcome, depending on what this algorithm is used to, you can look at calibration and discrimination, the sensitivity, positive predictive value. So I guess the question is more like, for example, in different subgroups, in different settings, the data quality, the completeness of the data. But the other type of the algorithm is actually to predict the treatment effect. Because in the old days, why they predict mortality or 30-day readmission or stroke? Because there are not many treatment options, right? So typically you use statin in patients with a high cardiovascular risk. So you just predict the risk, and when patient's risk is, say, above 10%, you will use statin. But these days, there are just so many different drugs and devices. So a lot of time these days, we are not predicting the risk itself, but rather the treatment effect or the difference in the outcome between the 2 drugs or 1 drug versus a procedure. So in one of the studies Peter and I did many years ago, so in the low-risk patients, you can see the benefits is not too big when you compare a procedure versus a drug because the baseline risk is low. But in some high-risk patients, the benefits is also not that great because many of them might not be a good candidate for the procedure. So you actually are searching for a most beneficial group. They are often not the highest risk or the lowest risk, but they have an interesting combination of a few different risk factors. And traditional clinical trials often just do the subgroup analysis, but we know that patients might have multiple factors. that can affect their heterogeneous treatment effect. So in some of our work, we use causal machine learning is essentially a ranking algorithm that rank patients from most likely to benefit to the least likely to benefit. And then similar to the AUC, you can actually get area between the two curves, because the green curve means, i.e., if you randomly rank patients, it will be a green line. It's more like a linear thing. And if your ranking really work, your cumulative treatment effect or the cumulative benefits will first rise and then decline, because the first quartile or the first top 20% are the patients who benefit most from the treatment. The other tricky thing these days is large language models, right? So how to evaluate LLM depends on how you plan to use it. Do you just want to use it for operational efficiency, or do you want to also use to inform screening, diagnosis, or even coding decisions? So these days, a lot of the more mature application is still in the clinical summary phase. So we currently evaluate the LLM generated, say, clinical summaries or notes from a few different aspects, right? The first is correctness. So the notes is generally free of the mistakes and incorrect information. You need to make sure the notes is correct. And we also need to make sure the notes is complete in terms of it doesn't miss important information. But we also don't want a 5,000-word essay of this clinical note, so it needs to be concise. And the appropriateness means that when patients talk with a clinician, sometimes they use casual language, but when you generate a note, you want them to be, the language to be more consistent with medical profession. And the last one is overall, the note is acceptable as it is, because this is also important if those large language tools is routinely used in clinical practice, clinicians used to seeing this note, it might be hard for them to catch a little bit mistake here and there, so the notes need to be relatively ready. Yeah, so typically it would be best to have blinded clinical reviewers, but it's not always possible. So the second stage is we rarely interact with an algorithm, right? So if you generate a number to a clinician, no matter what it means, they typically don't know how to do with it. So you generally would have an interface, help clinician interpret what this number means, and help display other information they will need from the EHR or from other places to inform how to make this decision. So this stage actually is more in the AI-human interaction phase and often involve mixed methods research, meaning both the quantitative and qualitative research can be surveys, multiple rounds of surveys, because the interface might evolve and we might do some modification at this stage. So one easy model we use in the survey is often the perceived ease of use, perceived usefulness, and the intention to use. So it's almost like a customer service, right? So is it easy to use? Is it useful for your specific task? And if you are given access to this tool, will you use it in the future? Or would you recommend to other physicians or clinicians? And the other thing is the trust in AI, because sometimes the low adoption is also due to they don't really trust the generated number or the results. So in one project, these are the questions we ask, and sometimes we do focus group too or one-on-one interviews. So it's like, how easy is it for you to spot any mistake in the summary created by this tool, and what % of your edits are related to just style or readability, and what % of your edits were to add missing important information or delete irrelevant information. Because from a technology perspective, we can track how many edits they made, but we want to know, or from a general sense, Because if most of the edits are related to the style or readability, maybe that's okay. But if most of the edits are to adding missing information and delete irrelevant or incorrect information, that might feed back to the data science team to or adapt the algorithm or revise the algorithm in some sense. So actually, most of my work is actually focused on the last stage to evaluate the impact in routine clinical practice. This is actually quite similar to evaluating any device or drugs. So the studies can be divided into randomized studies versus non-randomized studies. In non-randomized studies, you can do prospective observational study, meaning you might collect additional data that's not in your EHR, but specific to this technology. For example, if you want to demonstrate this tool, reduce the time for a clinician to write notes, then you might have to set up some mechanism to measure the time in both, either before or after, or in the randomization arm, in the intervention arm or the control arm. The other more easy way is to do a retrospective cohort study, just leveraging the data from EHR, so that will save some time from IRB. So we have two trials that evaluate AI in routine clinical practice. So Peter Noseworthy and I are PIs on those two trials. The first one was published in Nature Medicine. The other one was published in Lancet. So for this Nature Medicine one, it was actually conducted before the pandemic. It's one of the largest randomized trials to assess whether AI improves patient care in everyday everyday practice. So what we did is Zaki Attia developed a AI ECG algorithm, or he developed a number of. So this one is to predict low ejection fraction. So how this algorithm works in clinical practice is, if a clinician see a high risk from this algorithm, they should order a subsequent test called echocardiogram. So the algorithm generates about 6% of the alert among all the screened population, but half of the time, clinician or actually follow the AI recommendation, because there might be other reasons they don't want to order the echo either. I think common reason is because when you implement such algorithm, there need to be certain filters, right? So if a patient already have diagnosed heart failure, or so low ejection fraction means one type of the heart failure. So if they already have heart failure, if they have an echo already done in the past whatever time frame, we will not trigger the alert. But still, this is based on the EHR algorithm. At that time, we did use NLP to even capture heart failure from the clinical notes, but as you all know, when you use EHR data, regardless diagnosis codes or clinical notes, they are not entirely accurate like a clinician adjudicated case of heart failure. So sometimes you might be trigger alert, the clinician replies saying, I already know this person has heart failure, it's just your algorithm miss it. In other cases, patients are near the end of the life. The clinician feel like a new diagnosis will not change the management, so I will not have my patient undergo the echo. And cost, actually, we thought cost might be a big reason, but it actually wasn't. So how we did is, Mayo has primary care practice in Minnesota and Wisconsin. That's about 50 clinics. So at that time, we included 45 primary care practices. So at Mayo, the primary care is delivered by care teams. So there are physicians, there are APPs. So we randomize about 120 care teams, half to the AI alert, half do not have an alert. And then we compare the outcomes. So the other trials we did is actually a single-arm clinical trial. This trial is to evaluate a different AI algorithm. That's an algorithm to predict atrial fibrillation from the normal sinus rhythm ECGs. So ECG is electrocardiogram. It's like a graph. So when it looks like entirely normal to clinicians, but AI can see something that clinician cannot see, and then clinician will order a monitoring device to monitor patients for a longer period of time. So that's the rationale for this algorithm. But this one, we were not able to randomize the patients. So we basically have a single arm trial which everyone receive monitoring regardless of the high risk and low risk. So both the high risk and low risk got the monitoring, and then we borrow the real world controls from the EHR. So this trial was also called decentralized trial because these days, the centralized trial this name got really popular, but essentially it just means in the past when we do this kind of evaluation, we recruit patients at places like Mayo, and around their appointment, we recruit them, have them sign the consent form, and then we'll give them the monitoring, right? So these days with all the technologies, we can consent them remotely and screen them remotely and monitor them remotely, and all the data get back into the data platform. We are also doing an ongoing trial with Apple Watch, so it's also a fully decentralized trial in that the Apple Watch data get back to the Mayo data platform, and then we analyze the data. So in this Lancet publication, we recruit patients from 40 states of the United States, but you can see most patients are still in Minnesota, Arizona, and Florida because that's where our patients are, because we got our population from our own EHR, right? So of course, most of the patients are still in Minnesota. So the other thing I want to touch on today is like the tools to facilitate evaluation, because you kind of hear me talking about different things. So those AI technologies are not just the target for evaluation. They also facilitate the evaluation. For example, how do we screen like 1 million patients and get to the, say, 10,000 patients for trial enrollment? That rely on a lot of so-called phenotyping algorithm to screen the EHR record to see whether they have hypertension, heart failure, inclusion, exclusion criteria. And we communicate patients via text, via email, via patient portal, via app. So these are all the tools we use in routine clinical practice, because I'm not sure how many of you are familiar with the Current Center. So Current Center and the quality both report to the Chief Value Officer, Dr. Doughty. So a lot of our work actually is to evaluate certain quality improvement projects, like the fall prevention. So those kind of things also need pragmatic trials, but they also use those algorithms to abstract medical history. One is to support real-time clinical decision-making. The other is just to report on quality, to measure the quality, and then communicate with the patients. So the same set of a tool can be used in research to abstract medical history to determine the trial eligibility, track their outcomes, so we don't have to have clinicians adjudicate the clinical outcomes and invite patients and send follow-up information. So essentially, these tools help us transition from the traditional randomized trials to those digital-enabled randomized trials. So likely, most trials will not be fully decentralized. So most trials probably will fall in the hybrid, because some procedures we probably still need them to come to Mayo Clinic, while other trial procedures we can conduct remotely. So I guess that's so far for AI evaluators' perspectives. So typically when I approach a new technology like the machine learning algorithm, or these days almost every technology has some machine learning algorithm behind it, right? So we first want to look at the basic performance, especially across different race, gender, settings. And when you use those, I mean, most of you know this area far better than I do, right? Because when you carry a LLM or NLP algorithm from this institution to another institution, you might want to adapt the algorithm. And then we need to test the usability and acceptability of the interface. And this often is a mixed methods approach that you have to include a broad range of stakeholders, not just the MDs, probably physicians from different departments, the APPs, and even the administrators. And then the last step is to conduct either randomized or non-randomized study to evaluate the impact in large population. But we shouldn't jump there too fast because sometimes people are too eager to jump to a large study. But if no one really adopts this algorithm or they don't use it correctly as you intend to, then you are just wasting a lot of time going through the randomization. And fortunately, these days, we have a lot of digital tools to facilitate the evaluation. So does give us some promise, and I think the future is still quite bright. So, so I guess yeah. Thank you so much.